Well, good afternoon and welcome. Happy Friday. I'm June Simmons. I'm founding CEO of Partners in Care Foundation, and it's my pleasure to welcome you to, this is the third in our new series of vital virtual presentations to the community on issues we think are of critical importance and aligned with our mission. So today, as you know, we will be extremely proud to share with you a presentation by one of our great heroes, Dr. Elaine Batchlor, who's CEO at Martin Luther King Hospital, speaking to health disparities and the pandemic. Where do we go next? So, as you know, we're all experiencing this dramatic and disruptive pandemic. COVID has changed all our lives and impacted all our organizations, services, and daily life experiences, almost none at the level that Martin Luther King experienced, as you will hear. This briefing is going to bring you a deep view of some of those issues and the vital insights that are being gained as you know, we are now seeing things we knew about, but very critical issues around racism, health disparities, poverty, a host of issues that if we knew about them before, they are now blazingly clear to us, and the call to action is strong. So as background on why Partners is sponsoring this, of course it does, it ties to our mission. You know, for the past 23 years, our team has continued to work to pioneer new solutions. So while we do provide services, significant services, our overarching purposes as a change agent, and our services are the learning platform where we test innovations and work to build new models of care. And our focus is on what happens at home that impacts our health outcomes, and we like to partner then with hospitals, health systems, physician groups. We want to look at the resources people have, their knowledge, their skills, access to needed care, and as you'll be hearing shortly, lack of those things, the critically important social determinants of health. So part of our work at Partners is the development and scaling of evidence-based interventions to address those critical kinds of issues, and working to integrate social care and health care in order to really empower individuals to live in community homes of their choosing, to achieve best possible health and to master the challenges of poverty, of racism, challenges of aging. So we work across the region to bring safety net services to those most in need and provide extensive care coordination to follow people to support that continued community living over long periods of time. We're interested in consumer empowerment, systems change to really change community living models of care. So as the pandemic, we hope, is lightening, we look ahead with hope and excitement to reconnecting all of us with family, friends, and colleagues as more shots go into arms and new cases of the virus decline, at least in our region. We want to make sure we come back better. We cannot forget the critically important lessons that we are learning and have learned over the past year. The pandemic has shown such a harsh light on social and health inequities. A nice phrase that covers such tragic and widespread devastating outcomes in individual lives and across communities. These plague our Southern California communities and our nation. So today we really did want to focus specifically on the experiences of this one cherished urban critical safety net hospital that provides care to such overwhelming numbers, especially under COVID. these individuals who are already struggling with chronic medical conditions, poor health coverage, no health coverage, limited access to quality medical care, social services and supports. They, as you know, are among the hardest hit by this deadly virus. So we want to learn about what it takes to meet the needs of this highly vulnerable population in this hospital, which really faced a combat level crisis bursting at its seams due to skyrocketing demand for treatment. Now we see hospitalizations and deaths going down, so that the challenge then is not over. The next challenge, the imperative, is to give careful consideration to what it will take to finally level the playing field so the most vulnerable, impoverished Angelenos really come to have equitable access to social and medical care and the resources needed for a safe, satisfying, productive life and health. So just a couple of things before we start. I want you to know the session's being recorded, and happily it will be available, because after you hear it, you're going to be like me, you're going to want to share it. That's why we're having it today. It'll be available on YouTube. It'll be available through our website and also through the Martin Luther King Hospital website. We want to, of course, say we're not giving medical advice, although our presenter is a distinguished physician, so maybe we don't have to give that caution, but you know, we know you each should speak to your individual physician. We're going to have time for questions and dialogue. And there's a room at the bottom of the screen. There's a chat and a Q&A box that you can use at any time. And so with that, it is my honor to introduce you to really a wonderful colleague, a friend, and she's actually a former honoree of Partners in Care Foundation. We single out major, critically inspiring healthcare leaders. Dr. Elaine Batchlor, the Chief Executive Officer and the reopener of Martin Luther King Community Healthcare and Health System that really is a state-of-the-art private safety net hospital. 3 clinics, the MLK Community Medical Group, community population health programs, very innovative that you will hear about, and Philanthropy Foundation. So Dr. Batchlor's innovative work to increase access for underserved populations is really recognized nationally. She's earned her membership in the prestigious National Academy of Medicine, which is committed to advancing health science and accelerating health equity. In 2019, she was recognized as an Irvine Foundation California leader, a very special recognition. Before assuming leadership of MLK Community Healthcare, Dr. Batchlor served as Chief Medical Officer of LA Care Health Plan, which is where I met her, the nation's largest public health plan, providing care to a safety net population, massive, and also served as Vice President of Finance, Organization, and Operations at the California Healthcare Foundation, so distinctively has safety net, medical leadership, and philanthropic policy perspective. There she developed and oversaw research, policy analysis, and programs aimed at improving healthcare financing and delivery. So early in her career, she served as medical director for the LA County Office of Managed Care and as chief medical officers for Prudential Healthcare. So you can see that Elaine takes any challenge, has a broad array of settings and populations she's worked with. So she's, if not omniscient, widely insightful about all these issues. She is a member now of the California Hospital Association Board of Directors and the Hospital Association of Southern California and the Integrated Healthcare Association Board of Counselors for Partners in Care Foundation. So she's in demand. We're lucky she made time for us today. serves on the Health Affairs Editorial Board, an advisor for the UCLA Fielding School of Public Health and the Hospital Quality Institute. So on and on, you hear, I want to hear what she has to say when Elaine speaks. People listen. She's a Harvard alumna, and I might note proudly her two beautiful twin sons are Harvard students at this moment. So she's got a family tradition carrying forward. So with a bachelor's from Harvard, a master's in public health from UCLA, and a doctorate in medicine from Case Western Reserve, board certified in internal medicine and rheumatology. Woo woo. All I can say is you see why she's my hero, or should I say heroine? I don't know. Is there a neutral term? Anyway, she's great. So I am thrilled that she made time, and I know you will be instructed, inspired, and challenged by her remarks today.
So June, thank you for that wonderful introduction, and thank you everyone for joining us today for this very important conversation. I am going to run through a series of slides that will illuminate the COVID experience that we've had in South Los Angeles at MLK Community Healthcare, and talk about them as an example of how COVID has disproportionately impacted our underserved Black and Brown communities, and the direction I think we need to go in the future to mitigate long-standing inequities that made our communities more vulnerable to COVID than others. And if there's a takeaway from this conversation, that would be that we've had long-standing inequities in our low-income minority communities for many, many years that made them vulnerable to COVID, and that really impacted all of us. I hope one of the things that we've learned from this pandemic is that we are all connected, and the health of the least of us impacts the health of all of us. We've all been impacted by over a year of lockdowns and job losses and illness. And I hope that as we come out of the pandemic, we remember that we are all connected and that we need to take care of the least of us to take care of all of us. One of the things we've learned from the pandemic is the importance of public health and the fact that we have underinvested in our public health infrastructure. Well, I want to make the case here that we've also underinvested in community care for our low-income minority communities. And even before COVID hit, we have been dealing with an epidemic of poorly treated chronic illness in these communities. And it is that, along with other social determinants of health, that drove the disproportionate impact of COVID in these communities. So that's what I'm going to talk about. I think South LA is a microcosm of an underserved community that represents many other communities around the country where the same or similar conditions prevail and the same dynamics have been in place. So my hospital, Martin Luther King Jr. Community Hospital, is located in South Los Angeles. That includes the communities of Watts and Compton and Linwood. It is where the Watts riots broke out in 1965. It's a community that was created out of discrimination and racism. Why do I say that? South LA evolved because of housing covenants that prevented African Americans and Brown residents from living in the majority of Los Angeles County. Over time, South Los Angeles became a community of concentrated poverty that lacked access to employment, transportation, safe housing, good schools, and even healthcare. And the Watts riots of 1965 were fueled by anger over all of those ingredients. And one of the good things that came out of the Watts riots was the development of a new hospital in South LA, the old King Drew Medical Center. Unfortunately, over time, the medical center ran into some pretty significant problems and had to close in 2007. But I'm proud to have been part of bringing a new state-of-the-art hospital online in 2015 to serve the same community as a private safety net hospital. So we are a small community hospital, 131 beds, but we are taking care of a pretty large community that has pretty significant needs. The majority of our community is people of color, you can see on the screen there, and low income. And much of our service area is federally designated as both medically underserved and health professional shortage areas. Next slide, please. Some of the significant disparities in our community include a shortage of 1,200 physicians, and that includes 500 primary care doctors and 700 specialists. The shortage of physicians is directly related to the fact that this is a low-income community that is primarily insured through Medicaid or uninsured, and the Medicaid program, as many people know, is the lowest rung of our tiered healthcare system in this country, with commercial insurance on the top tier, Medicare on the next tier, that's the program that covers people over 65, and Medicaid on the bottom. And just to give people a comparison, for the same type of emergency room visit, the average payment to a provider from commercial insurance is around $2,000. $650 for Medicare, and $150 for Medicaid. So those disparities in payment drive disparities in access and quality. And we see an epidemic of chronic illness with a high prevalence of diseases like diabetes in our community. You can see there it's much more prevalent in South LA than in the rest of the state. We see shorter life expectancy, and we see the impact of all of the social determinants of health that I mentioned earlier. Next slide, please. This slide is another example of the structural inequities in a community like South Los Angeles. Our community, which is represented by Service Planning Area 6, this is from the LA County Department of Public Health, and the statewide Office of Health Planning and Development, shows that South LA has many fewer hospital beds even than every other area in South Los Angeles, and it's pretty striking there. Next slide. This is a profile of our patients in 2019, immediately before the COVID pandemic struck. You can see that 25% of our patients were coming in for diabetes-related problems. The most frequent surgical procedure we do is diabetic amputations and wounds. These are procedures that are preventable with appropriate outpatient management. So they directly reflect a failure of the health system. Even though we are not a psychiatric provider, we have over 10,000 patients with primary mental health conditions presenting at our hospital emergency department every year. And de facto, that has turned us into a behavioral health provider. 25% of our patients have comorbidities that include substance use. Around 10% of our patients are homeless. Our emergency department, that was designed to care for about 45,000 visits a year, in 2019 provided 110,000 visits. Many of these patients were coming in with end-stage illnesses that were a reflection of years and years of lack of appropriate care for chronic conditions like diabetes, hypertension, heart disease, pulmonary disease. And we also had many people coming in for low acuity conditions that in other communities would be cared for in urgent care facilities and doctors' offices, but those places don't exist in adequate number in South LA. Next slide. This slide shows you the profile of our patients in 2020, which is the year that COVID took over. Normally, sepsis would be our #1 inpatient diagnosis. Sepsis is a serious infection that is often the end stage of poorly treated chronic illness. In 2020, sepsis was overtaken by COVID-19. You can see the other conditions that we treat that are again reflections of poor management in the outpatient setting. Heart failure, which has a high prevalence in our area, chronic obstructive pulmonary disease, which is also highly prevalent in our area. And you can see the comorbidities that our patients present with. What's of note is that our patients are typically a little over 50% Hispanic and a little less than 50% African American. And I'm pointing that out because I'm going to show you a profile next of our COVID patients, and it's going to be significantly different. You can also see that our patient population is almost completely publicly insured, with Medicaid being the predominant insurer and a significant percentage of our patients being uninsured. Next slide. So this is a profile of the COVID patients we cared for in 2020. And I will note that as of April, we are now up to approximately 4,800 COVID patients, but these are the COVID patients we saw through 2020. So the first thing I'm going to point out is that 80% or close to 80% of our COVID patients have been Latino. And you'll recall I said, a little over 50% of our overall patients are Latino. So there's a big disparity right there. The other thing that we noticed is that many more of our COVID patients are uninsured. And that probably goes along with the higher percentage of Latino patients. 82% of the patients who presented to the hospital with COVID had at least one chronic condition, and over 50% had 2 or more chronic conditions. And you can see the most prevalent are heart disease, diabetes, behavioral health conditions, obesity, and kidney disease. The rate of admitting patients to the intensive care unit was similar to the rates seen at other hospitals, about 20%, and ventilator rate of about 11%. One of the interesting things about our patient population, and our Latino patient population in particular, is that they were less willing to go on a ventilator when their physician recommended it, and they tended to wait later in the course of disease to agree to mechanical ventilation. Next slide. Now, what this slide shows is every hospital in the Los Angeles area that is within 15 miles of Martin Luther King Jr. Community Hospital. And it shows the number of licensed beds at those hospitals and the number of COVID patients those hospitals had the week of January 8th to January 15th of this year. And then on the very right, it shows the percentage of COVID patients per licensed bed. We found this information during the winter COVID surge, the federal agency, Health and Human Services Agency, began to publish on the internet the numbers of licensed beds and COVID patients in every hospital across the country. Hospitals were required to report the numbers of COVID patients they had every day. When I stumbled upon this information, I was shocked to see that our small 131 bed hospital was caring for more COVID patients than hospitals that are 3 to 4 times larger. I was surprised by that. And this pattern was consistent throughout the winter surge. We had many more COVID patients than we had licensed beds. And we became the epicenter of the Los Angeles epicenter of California. Now, you may be wondering, why were we seeing so many COVID patients at this one small hospital in South LA? Well, it's a combination of underlying conditions, medical conditions, the limited number of hospital beds, and the things that are outlined on the next slide. Next slide, please. South Los Angeles is where many of our essential workers live. These are the people who were not able to hunker down and stay at home during the COVID pandemic. These are the people who continued to go to work, stocking our grocery stores, cleaning up after us, taking care of our children sometimes, cooking in restaurants, working in factories, and doing all of that with inadequate protection. Whenever I went to my local grocery store and I saw people coming into the store without a mask, I really felt angry for the people who worked in the store who were being continuously exposed to COVID. We also know that there was insufficient testing and tracing, particularly early in the pandemic. We saw many, many patients in our emergency department that were diagnosed as having COVID, but where there was no test available to confirm the diagnosis. And our doctors would tell their patients to go home and isolate, but they weren't able to tell them that they had a positive COVID test. We also know that many of the people who live in our community live in crowded housing. So you can tell someone to go home and isolate, but if you've got many people living in a small apartment or house, it may be impossible for them to isolate. And we saw many family members coming in together with COVID. Once one member of the family got it, other members of the family got it. We also know, as we talked about earlier, that our community has many more people with poorly treated chronic health conditions that make them vulnerable to the more serious complications of COVID. We also have some evidence that people who live in communities like ours don't seek care as quickly as others. There was actually a study that was done at Sutter Health System looking at when people presented in the course of their COVID disease. And they found that their African-American patients actually came in later than their other patients. We also know that they also generally are getting less access to high quality care. And then we know that they live in communities that are significantly impacted by the other social determinants of health as listed here. Next slide. So when people talk about structural racism and institutional racism, we don't frequently drill down and talk about what that means in concrete terms. And what I'm trying to do today is I'm trying to really connect the dots and help you understand what structural inequities look like. So the number one structural inequity that impacts access to quality health care for our community is no or lower quality health insurance. We already talked about the fact that the Medicaid program that insures most of our community pays providers very low rates compared to Medicare and commercial insurance. And as a result of those disparities in payment, we have disparities in access and quality. Another issue is underinvestment in community-based prevention and disease management. Now, what do I mean by that? Well, as a hospital, we receive supplemental funding on top of the low reimbursement that Medicaid pays. And that supplemental funding allows us to provide high quality care and to be financially sustainable. Outpatient care doesn't get supplements. So we have a whole community of providers, or we should have a community of providers who are doing prevention and managing diabetes, hypertension, et cetera, heart disease, and they are not there because of the low payment rates that Medicaid pays for community-based care. So I like to say, as a hospital, we get paid adequately to amputate a diabetic limb, but we don't get paid adequately to manage the diabetes and prevent the limb from being amputated. I think it's important to point out that primary care and federally qualified health centers cannot meet all the needs of underserved communities. One of the things that gets me very frustrated is this prevailing mythology that all low-income minority communities need is more primary care and more federally qualified health centers. Yes, we do need more primary care, and federally qualified health centers do a wonderful job of taking care of their patients, but they cannot meet all the health needs of a community. Would you live in a community that didn't have a continuum of care, that didn't have appropriate specialists, that didn't have surgeons? You probably wouldn't. Why do we expect minorities to live in communities like that? Why do we think it's okay for the emergency department to serve as a medical home because primary care physicians can't get paid enough to maintain a quality practice in this community? And then the third structural inequity I want to highlight is a lack of diversity in the health professions. We know that African Americans and Latinos are very underrepresented in the medical profession. And we only need to look at what's happening with the COVID vaccine to understand why that matters. You know, trust and rapport are important components of healthcare. And you're much more likely to be able to establish a trusting relationship with people who understand your language, your culture, and who frankly see someone who looks like them. This is a significant issue. We also know that minorities are more likely to want to practice in minority communities. But again, the financial incentives are not aligned. One of the structural inequities that contributes to the lack of diversity in the health professions is the way that we fund and pay for graduate medical education. So this is the medical education that trains our doctors when they finish medical school. Not to mention, you know, the hundreds of thousands of dollars of debt that individuals have to take on in order to get through medical school. As a safety net hospital that is starting graduate medical education programs, I was surprised to learn that most graduate medical education is funded through Medicare. And the amount of funding that a provider gets for GME is directly related to the percentage of Medicare patients they take care of. That means that a hospital like ours, that is primarily taking care of Medicaid patients, receives less funding for training doctors than a hospital that has a lower percentage of Medicaid patients. So for example, we project that we will receive about $55,000 per resident per year, while hospitals on the west side of LA are receiving $180,000 per resident per year. So this is a structural inequity. Next slide. So what is the solution? Well, the solution that we are working toward is creating an integrated, high-quality system of care for our community. And we believe that an integrated system includes more than primary care, and it includes more than inpatient care. It includes appropriate post-acute care. So these are the nursing homes and rehab programs that people often need after a hospital visit. It includes multi-specialty outpatient care. It includes population health programs. We have some vulnerable populations that need care that is specifically tailored to them. One example is our homeless population. It includes community health, which means education, screening, connecting people to a medical home, and it means prevention. Next slide. So one of the steps that we've already taken to develop this integrated system of care for South LA is the development of a multi-specialty medical group called MLK Community Medical Group that is focused on expanding access to community-based prevention and disease management. And we are trying to fill the gaps in our community. We know that we have a number of federally qualified health centers that are doing a great job of taking care of children, of taking care of women, of acute episodic care. What we really want to focus on is adults with significant health challenges. For that reason, our medical group is specifically multi-specialty. We're also focusing on developing virtual and mobile care. An example of mobile care is street medicine for our homeless patients. So we know that a lot of our homeless patients are on Medicaid and belong to a Medicaid managed care program, have been assigned to a primary care physician in a medical home, but they live on the street. They don't have transportation, and they aren't actually ever seeing those doctors. When they need care, where do they go? They come to the emergency room. And they come to the emergency room, over and over again when they need care. We're trying to create a different paradigm. We connect with our homeless patients when they're in the hospital, and we do follow-up wherever they are on the street. And we try to stabilize and maintain their medical problems and help them get connected to housing. One of the new innovations we've created since COVID is a multi-specialty post-discharge COVID clinic. And it was started by one of our pulmonary ICU doctors who was caring for a lot of our COVID patients in the ICU and worried about what would happen to them when they left the hospital. He doesn't have to worry anymore because now he's able to see them in the outpatient setting, along with the nurses that cared for them during their ICU stay. And we also have the spiritual support, the behavioral health support, whatever specialty is needed to help get these patients back on the road to good health and to keep them progressing in their recovery. We also think it's really important to create some centers of excellence for managing chronic conditions. So these are the patients with diabetes, with high blood pressure, with heart disease, with pulmonary disease, kidney disease that we see in crisis in the hospital. We want to prevent those crises, and we want to help them do a better job of managing their health on a day-to-day basis. We're proud that our medical group was recently NCQA certified for diabetes care. The hospital is going through a Joint Commission certification for diabetes care. We are opening a new wound center in a medical office building on campus that will have hyperbaric oxygen and will be able to help us preserve limbs for our diabetic patients. So we really want to have the full continuum of care and service that our patients need. We also have dental services, and we want to address the social determinants that are impacting their health. One of our most successful programs in that area is something that we call Recipes for Health. This is a program that provides fresh produce for our food insecure patients who have conditions like diabetes and heart failure that require attention to diet. In addition to providing produce, we also provide cooking classes. We go shopping with them and show them how to read food labels. And as long as they continue to keep their medical follow-up appointments, we continue to provide the food. One of the happiest moments for me is when I'm in the lobby of the hospital and I see someone coming by the hospital to pick up their bags of produce. We recently completed a one-year evaluation of this program and found that it has changed eating habits of entire families. And we're in the process right now of creating a program that's focused on the needs of children and making sure that we are providing appropriate food for kids. Next slide. Now, all of these outpatient programs that we are developing and growing are not adequately supported financially. So the long-term sustainability of all of those programs is in jeopardy if we don't see changes in how the care is reimbursed. You know, we can't maintain all of those programs on Medicaid payments. We were fortunate to receive some very generous philanthropic funding that allowed us to start this medical group and to hire the highest quality physicians by offering market compensation. And the hospital is able to subsidize the group. But over the long run, we need change in how services are paid for in the community. So I've put together, these 5 recommendations for advancing health equity after COVID. Number 1 is to invest in infrastructure and payment for community-based care. We cannot focus all of our investment on inpatient and crisis care. It just doesn't make sense and it's not right. We also need to reduce the disparity in payment across payers and insurance programs. By maintaining Medicaid payments at the lowest tier, we're basically saying it's okay to have a separate and unequal health system with a bottom rung that is not adequate. We also need to integrate medical and behavioral health care. So one of the things that we're doing in our medical group is we're providing those services in the same place at the same time. And what we found is that many patients with chronic medical conditions also struggle with substance use and/or mental health conditions. And you're not going to improve their pulmonary disease that's exacerbated by substance use unless you address the behavioral health conditions at the same time. I don't think I need to, lecture people about addressing social determinants of health. I think the fact that you are in the audience probably means that you already understand the importance of that. And we need to increase the diversity of our healthcare workforce. So I'm going to turn off the slides at this point and turn it back over to June so that we can engage in a little bit of dialogue.
Well, we're in the room, we would have a standing ovation to thank you for not just a great presentation, but remarkable work by a remarkable team that you've assembled. It's very inspiring, and we can hear you rising to an occasion that is so dramatic and so well documented. I think it's so important for us to understand the structural drivers. And there's so many things you said, but if nothing else, just the shift from $150 to over $2,000 for an emergency room visit for the same care is so shocking. It just informs us. And so I know that you're doing brilliant, great work with a wonderful team, but then we can hear the odds that you face and the struggle to build resources to make these terrific innovations occur. So we applaud you. So yeah, we do. Do we have some questions in the Q&A? Some questions in the chat? I don't.
While you're looking for those questions,
Yes.
June, I will say that one of the things that I'm spending more and more of my time on is policy advocacy, because as you can see from reading the recommendations at the end, a lot of these issues are tied to policy decisions that are being made and that have been made. And the way to make progress is to change those policies. One of the books that I wanted to recommend to your audience that I recently read is a book called The Political Determinants of Health. And this book talks about the fact that all of these social determinants of health are driven by policy decisions that are tied to the political system. You know, the people who are elected to make those policy decisions and to carry them out. And, you know, if we want to make real change, we're going to have to go, just like we have to go upstream of the hospital, we're going to have to go upstream to where those policy decisions are made. So, you know, I've been spending a lot of my time trying to raise awareness about the disparities in communities like ours and to make people aware of the structural and policy determinants of those disparities that we need to change.
Well, I know in California, one of the important things underway at that level is the redesign of Medi-Cal, the CalAIM initiative. And I wonder if you have some top priorities. I think it's very exciting that our state is looking more broadly at whole person care and trying to address some of these issues, but I wonder if you want to comment on that at all.
I think it's great that we are looking at the social determinants of health and we're thinking more holistically about health. But I'm going to be honest with you, I find it a little frustrating that you know, we're willing to pay for social things, but we still aren't willing to pay adequately for healthcare. And I do feel that the fundamental issues that I talked about, which is the disparity in payment and the fragmentation of payment, you know, so I think we have three big issues. One, the disparities in payment, that, you know, that Medicaid is so low compared to Medicare and commercial. Two, that behavioral health is cleaved off from medical care. And three, inpatient care is subsidized and supplemented, but outpatient care is not. So we need to change those things. Otherwise, I sort of feel like we're rearranging the deck chairs on the Titanic.
Well, I think, you know, your candor is critical. And so all of us, I think, want to rise to these occasions where there is an inflection point where redesign has been raised as a proper challenge, and we should join you in that quest, as you know. We're going to redistribute resources. We want to get it right. This sort of thing does not happen frequently. And so it's a critical moment to just try to get it right. So
you know what I think, June? I
yes.
think that to get it right, we as a society need to change our priorities. And, you know, we have built this ridiculous industrial prison complex. And we've put more and more people in prison, and we've spent more and more money on the criminal justice system. And by the way, my husband is a criminal defense attorney who works for the Los Angeles County Public Defender. So he's been doing indigent defense his whole career, and I've been, you know, sort of watching that. So when people want to know where's the money going to come from, well, I think we need to change how we're spending our public dollars, and we need to change our priorities and spend more of our money on social goods and less of our money on locking people up for using a drug. So, you know, that's really what I see. And it does frustrate me when I hear the state say, well, we'll pay you $400 for care coordination, but they won't pay for the specialty care that a patient needs.
So it's vitally important to lift these, and we are seeing all the struggle in our nation around the justice or lack of justice system, and I believe these issues, like some of these healthcare issues, are coming to the fore. But then that's the moment when we must seize and find the strength and power and influence to really make the significant, fundamental, transformational changes you're speaking to, because these are, as you say, the people who are put in prison. It's like sending them to the trash heap, because then their lives are really interfered with forever, whether it's the bail system or it's the disproportionate conviction and imprisonment, and then the lack of resources if someone does get out. These are, as you say, such damaging events for the person and the people around them. It's critical. So your anger, you know, is a guide to proper reform. So we need to join you. And we need then, I saw a comment actually in my text saying, now how do we educate, how do we spread this further? So one way is that all of you watching could take this presentation, you can share it widely, because it is being recorded for that reason. This should not be a select group of us with the privilege of hearing these insights, this passionately held delivery of diagnosis and solution for critical systemic problems. But we should take these to the street. We should take these to our colleagues, to our institutions all around us. And so I think that's a call to action that would make it have been a meaningful investment of Dr. Batchlor's precious time being one of the, well, it is, you know. It's a gift you're giving us, because it's a resource and it's limited.
And
so
that's why we're talking about it, because we need more people to be aware of the situation, and we need to, you know, push for change with our policymakers.
So we will take one step besides having it available to send out to everyone who registered for this, a call to action to share this information. That's something we can do, and ask to ripple this out. And then we will see, did we invite everyone we should have? And others that we invited that maybe you think didn't attend, we will lift that. So I think that these are things we can do, because as you say, you cannot treat what's not diagnosed. So here we have a diagnostic, we have an early treatment plan, and now the hard work to achieve meaningful change in our society is what's really called out, and called out with great and clear urgency.
So June, I put two
Yes.
books in the chat
Oh, good. Okay.
area that I would recommend to people who are interested that
Please.
have really helped me. One is The Political Determinants of Health, and the other is a book called The Sum of Us by Heather McGhee. It was on it. I think it might still be on the New York Times bestseller list, and it's about the role of racism in undermining services and care for everyone. So, she starts out that book by saying, why can't we have nice things in this country? And by nice things, she means childcare, healthcare, infrastructure that works. And she traces it back to racism. And one of the analogies or metaphors she uses in her book is the metaphor of the public swimming pool. So there was a time in our country's history when communities had very elaborate public swimming pools that were a place where people could come together and socialize and enjoy. And these swimming pools were large and very elaborate, but they excluded African Americans. African Americans were not allowed to swim in the pools. Well, African Americans went to court and said, hey, our tax dollars are helping to pay for these pools. Why can't our kids swim in these pools? And the courts agreed with them and said, African Americans have the right to swim in these pools. Well, what the communities did in response is they filled the pools in with dirt and closed them. So no one had access to a pool. And in some cases, they turned the pools over to private groups that created, private country clubs, and people started putting pools in their backyards. But it really took away an asset that was an asset for the entire community. And she draws a connection from that to other types of social goods that we are missing in this country that are present in other Western countries that have a robust safety net and that have done much better at supporting their citizens through the pandemic because of that.
So that is a vitally important read for us. And when we send out our call to action for those who signed up and others we want to re-invite, we can include those as a recommendation from you. We'll get a little more detail about the author and so on, and that's so important because it's true. If you're going to I always watch sports. I'm not a sports watcher, but I watch in our country the change. And you think about the talent pool, it's the same thing as privilege that you're saying. If we restrict privilege for one, we restrict privilege for ourselves. That's the same thing if you look at sports and you realize how many hundreds of years we left out of the talent pool some fantastic talents that now we see how disparate our choices were, and then how we lowered the whole sport, how we lowered proper competition. So all of these ways of exclusion have a broad social price that impacts all, one way or another, as you note.
So I'm seeing some questions here in the Q&A box.
Yes. Mm-hmm.
And so there's some questions about, what can we do to improve the diversity of the healthcare workforce? And I think that we need to invest more in supporting people of color who are interested in working in the health professions. The fact that you have to go hundreds of thousands of dollars in debt in order to go to medical school is just ridiculous, and it's a barrier for low-income people. So I think we need to provide more funding to help those individuals get through school. One of the things that we are doing at the hospital is we are raising money so that we can pay the tuition for our staff members who want to go through nursing programs and become nurses, because we really want to have a diverse group of nurses. We're going to be starting graduate medical education at the hospital. We know that doctors are more likely to stay in the communities where they train. So we need to have training programs in those communities, and we need to close the gap that I told you about earlier in support for those graduate medical education programs. Again, these are policy decisions that are driven by the people we elect to office and the people who run the agencies that oversee these programs. And the number one thing you can do to be a part of change is vote. And, unfortunately, a lot of young people don't vote. We need more of them to vote and, to get involved in encouraging other people to vote.
At a time when voting is being challenged, at
Absolutely.
least in other states.
And then,
Fortunately, not in ours.
It's funny, this morning I was sitting in the kitchen. My son, one of my sons, is teaching a civic engagement class to fifth graders at a public school in Boston. And I frequently sit and listen to him teaching this class. And this morning they were talking about what the kids can do to be civically engaged. And they talked about voting. They talked about, writing letters to your representatives. They talked about participating in demonstrations, volunteering on a political campaign. My sons have done canvassing in political campaigns since President Obama first ran for office. We drove to a swing state. We drove to Las Vegas, and we went door to door canvassing with them. So there are always things that we can do to influence policy in this country, but to do that, we have to be engaged and involved with the political system.
Very, very true. There's a question, if you would tell us a bit about your hospital staff and your community care staff, their heroism and sacrifice in the face of a global pandemic. I wonder if there's something you'd like to share about them. They must be an amazing crew.
Well, they are an amazing group. And, the first thing I'll say is that over 80% of the people who work at our hospital are people of color. So we have an incredibly diverse staff. But we also have a very talented and very dedicated staff. And the pandemic put us all under a lot of pressure. We had more patients more COVID patients at our hospital than many other hospitals that are larger, that have more resources. But I have to tell you, I don't think any hospital did a better job of taking care of them. Our staff was amazing. We never ran out of supplies. We never ran out of equipment. Every time I thought we had come up against a limit to how many people we could care for, they came up with a plan for how to expand our capacity. One day they told me they were going to convert an entire medical floor into an intensive care unit. And they did that within a few days and moved all of the intensive care unit patients onto a medical floor where they had, 10 more beds than before. So they could expand the number of patients they were caring for while still doing an efficient job. We had 5 tents out in front of the hospital so that we could keep COVID patients separate from other patients, and so that we could continue to take care of the large number of patients we have with behavioral health conditions. And the nurses and doctors who work in our outpatient practices came into the hospital and started taking care of patients inside the hospital. On Christmas Eve, I sent a letter to the governor, and I said, we are the epicenter of this pandemic. Let me tell you what's happening here in South LA and at my hospital. And I was really pleased that on December 26th, on the day after Christmas, at 6 o'clock, he had a whole team of people who came to our hospital from Sacramento to see what was happening and to find out what we needed. And we subsequently had the National Guard come in to help. We ultimately got about 90 traveling nurses and also got a team of respiratory therapists. And, we really were able to take care of our patients through all of that support that we got and the dedication of our hospital team. And, the surge is over now. It's really astonishing. I was looking at the number of COVID patients today, and it looks like we have, 5 COVID patients in the hospital now.
Wow.
So hopefully that will hold. And, people will continue to observe the public health guidelines and get their vaccinations.
Well, it's like you were in a combat zone and you did whatever it took and amazingly rose to that occasion. So probably a Medal of Valor to your whole team would be appropriate.
Absolutely. And I saw a question in here about technology and information technology. And one of the areas that my staff pivoted to very quickly was telemedicine, and really did a lot to promote telemedicine as an alternative to coming to the emergency department or going to see a doctor. We put all sorts of resources on our website. We actually contracted with a telehealth company to provide telemedicine visits for uninsured people who live in our community who didn't have a provider. And we also developed something called a chat bot that is also on our website. Her name is Mia, and Mia answers questions about COVID and about the vaccine and helps people find care and figure out how to get the vaccine. So what we discovered is that people in our community really like using telemedicine. The no-show rate for our in-person outpatient visits was over 50%. The no-show rate for telemedicine visits is 7%.
Wow.
So we found that people really, it really worked for people because it's convenient and it doesn't take transportation or time, driving to an appointment. So we're really investing in virtual care. We're also investing in care at home. So one of the things that we also started doing through the pandemic is developing partnerships that extended the care into the home. One of the partnerships we developed was with our ambulance company, and we started doing paramedic visits to people at home to monitor them and to catch any signs of deterioration early so that we didn't have people unnecessarily bouncing back into the hospital. And we are doing a lot of investment now in biometric monitoring in the home and being able to follow people after they leave the hospital to make sure they're doing well. So we are definitely leveraging technology, and we found that our community is responsive to telehealth solutions.
That's fantastic. So one of the things to advocate for is going to be continuing payment for telehealth equal to office visits and telephone only, not requiring visual, because these are one of the policy issues. Yesterday, the California Evolving Technology Fund, CETF, reported out the results of a listening session that they had heard, and they have a new report out because another structural barrier in our country and in our region is the lack of adequate broadband. It's a form of redlining, if you will. Yep. And there's money coming for that. And once we have that, then we're going to also have to figure out how to get people devices who don't have them, how to train them to use them, how to give them confidence in that, especially older populations are kind of more device phobic. Young ones can't keep it out of their hands, but it's not evenly distributed. And so yes. I think these are also important policy and structural issues because, as you say, the virtual visit, if the healthcare professional doesn't need to touch you, then you can do it virtually.
Yep, and I agree with you.
There's no driving, there's no waiting, there's no exposure to others. It's more efficient.
No PPE.
Exactly. Yep, so
it's a great alternative. So I see a couple of other questions there. There's one about that says our existing data systems that track COVID-19 outcomes adequate enough to identify disparities. And I do think that the data is there. It's just that it's in the hands of the public health people. You know, all of the hospitals have been required to report COVID data. But one of the things that we've really lacked is transparency around the data. So I know what's going on in my hospital, but I didn't know what was going on in other hospitals. And when HHS started publishing the numbers, that was the first time we were able to get a look at what was happening in other hospitals. And as a result of the letter that I wrote to the governor, LA County convened a meeting, a regular meeting of the leaders of all of the hospitals in the county. We started out meeting every day during the height of the surge, and then we sort of spread the meetings out. And one of the things that was happening during these meetings was the public health department started sharing data on the numbers of patients in different hospitals. What we didn't really look at was outcomes. And I think that once we've gotten through the surge, we will be able to start looking at outcomes and comparing outcomes. But we also have to be careful that we're comparing apples to apples and oranges to oranges, you know, that we're comparing patients who have similar comorbidities and who present at similar times during the course of their disease, so that we can understand some of the variables that have driven the differences in outcomes. But I do believe that the data exists, but it's not in the public domain yet.
Yes, go ahead.
There's a question here about how organizations recruit quality healthcare workers and retain them. And I would say that, you know, the answer to that question is multifactorial. You know, it has to do with leadership, with culture, with mission. I also think that you have to compensate people fairly, and, you know, you really have to provide market compensation, and that means salary and benefits. And if you don't pay people fairly, you're not going to recruit and retain the best people. But you also have to provide an environment that has a supportive culture, and, you know, a culture that encourages teamwork and excellence and compassion and flexibility and autonomy. I think those are all important parts of recruiting talented people and retaining them.
An inspiring leadership like yourself, I'm sure, plays a role. Do you have a way of touching in with your staff during these dramatic times so that they get to experience you, your values, your culture? Can you talk about that?
Absolutely. So, you know, we established right from the beginning, we established a practice of me talking to every new employee who comes to work at the hospital. So, you know, telling the story of how our community evolved, how our hospital evolved, what our values are, what my personal values are. You know, one of the things that I used to tell all of the staff is that at our hospital, patient care and patient needs come first, not money. You know, we don't make decisions based on money, we make decisions based on patient need. But at the same time, we have to be good stewards of resources, because we all know that healthcare is too expensive and a lot of people are having difficulty affording it. And that means that we have a responsibility to use all of our resources carefully. So it's really passing along those values and expectations that we do. You know, I meet with my leadership team every week. We have regular all staff meetings. We have regular management meetings. We have opportunities. We have rounding, you know, regular rounding. So we have one of the things we have that I think is really wonderful in supporting our culture is an online little email that goes out once a week that we started during the pandemic that we call Know, Do, Share. And it shares information about what's going on in the hospital. It also gives staff an opportunity to shout out other staff members who are, you know, really going above and beyond in living our values. So it's a wonderful way of sharing with everyone and reinforcing with everyone our values and our culture.
Beautiful. I see a very nice question from Dominique Addison. Says MLK Hospital's where she was born, and it's the community where she currently lives, and wonders how, as a member of the community and an employee of the healthcare system, educate people in that community as a resident, as a respected resident.
Mm-hmm. So is she asking what we're doing around community outreach and education?
What she can do.
Oh, what she can do.
I believe, am I correct, Dominique? I think so.
Yeah, so we do have a volunteer program. We also have a program for students of various levels who are interested in, learning more about working in a healthcare environment. And if you go to our website, you can download some information about both of those programs. On the community side, we have a formal population health program here at the hospital that is led by a physician, Dr. Jorge Reno. He is an internist and an infectious disease specialist, and he is developing all of our population health programs, and he is also overseeing our community health. And prior to COVID, we had established relationships with barbershops and schools and other types of community-based organizations where we regularly do health screenings and health education and connecting people with medical homes. Each of the barbershops has a physician mentor who goes to the barbershop and talks to men about health topics and trying to meet people where they are rather than forcing them to come to where we are, and really using community-based venues as places to educate, screen, and connect individuals with healthcare. We also use community health workers, and we use them for care coordination and care navigation, both in the hospital and in our outpatient practices.
Fantastic, and we hear then serial innovation, creatively discovering new pathways to bring people to care and care to people, those most in need, which is beautiful. And I know you will continue because somehow you have a way of discovering new pathways. So this is I think, also probably inspiring to your staff. Maybe they come with ideas and you hear them and implement them so that you're worth talking to, which you clearly are.
I love the ideas that come from our staff. Just to give you an example of a few of them, during the COVID pandemic, one of our ICU nurses, young woman who was an ICU nurse, was working with a young mother who had kids at home, and she was not doing well with COVID. She was dying. And we all know that during that period, we were following public health recommendations to not allow visitors in the hospital. Well, this young woman was so affected by the patient that she took care of, who was not able to see her young children when she was dying, that she came to us and she said, I really think we should change our visitation policy for patients who are at the end of life. And we said, yes, you're right, we should. And we did. And it was that simple, and we started allowing visitors in at the end of life.
Wow.
And that was a policy change at our hospital that came about not because someone in the C-suite said, hey, let's change this policy. It came about because of someone who worked on the front line who said, this is not the right way to do things.
They observed suffering that could be addressed differently and alleviated.
Exactly. And that's the kind of culture that, we really want to encourage at our hospital, where the people who are closest to our patients and to the work are making suggestions for how we can do a better job. It was our ICU doctor who said, we need to develop a post-COVID, post-ICU clinic, and this is what we need to put in it. And we said, you're right, go do it. It was our nurses who were taking care of patients with congestive heart failure who noticed that the same people were coming back over and over again. And they noticed that their patients didn't seem to understand the basics of taking care of their heart failure at home. And they developed an education program. And we said, wonderful. They got scales and, did they develop booklets and, the whole 9 yards. And then we spread it throughout the hospital. So it's often the people that do the work on the front lines who come up with the best ideas for how we can do a better job. And we want to have a culture where those ideas are respected and nurtured. Now that the COVID surge is over, we are focusing a lot of attention on vaccination in the community. One of the tools that we have is what we call hot spotting. So we know where the highest density of COVID cases are in our community, and we've been able to target those locations for mobile pop-up vaccination clinics. So we have a clinic at Freedom Plaza near Jordan Downs Housing Project. We have a clinic in the parking lot of Superior Groceries in South LA. We've had clinics in Boys and Girls Clubs. We had a clinic at the Senior Center. We're going to where the patients are and doing those vaccinations. And we're now doing thousands of vaccinations a week. International Medical Corps donated 2 additional vans for us to use in our mobile clinics. We're also partnering with Cedars-Sinai, who's also providing resources. And so we're really focused on trying to get as many people in our community vaccinated as possible. Another example of our community outreach.
It sure is. Well, I'm sure one of the reasons that your staff stay, as they've stayed through, we can hear what was tremendously demanding, disruptive, and now we're hearing in the news, how harmful to people some of these magnificent, heroic service opportunities have been for them. What they've seen and what they've gone through is that they own the place with you, that you're really sharing ownership of the leadership, and that they're not, that they're able to really have impact by bringing their most heartfelt observations and actually changing something. It's so empowering. So that leadership, I think, is very powerful.
Well, people often ask me, how are you successful? And what I say is that I'm successful because I have smart, talented, energetic people working for me, and I let them do their job. I let them bring ideas, and I support their ideas, and that makes me look good.
But it also is, people are helpless otherwise. They see things that they care so deeply about if they can't do anything. So the ability to be able to actually bring something forward and get a change, like people not dying alone.
I'm an optimist. I believe in doing things that other people say can't be done.
And you're showing that it works. It's true, without hope, but there's no point. So you have to have that vision. I do see another question, maybe ties to that in another way. It's not in the chat, came to me on the side here. The role of CEO in an urban safety net community hospital seems overwhelming to many of us, which I'd have to agree. Your personal strength, resilience, and fortitude is amazing. You've dealt with so much over the last 16 months, so this person is asking, are there still things that keep you awake at night? Or maybe you sleep well and that's why you're able to lead this way. I don't know.
What I would say that what keeps me awake at night is what I talked about earlier, which is, the structural inequities in our system that I feel so strongly need to be changed. That's what keeps me awake at night, is thinking about how we get those things changed. And particularly when a lot of the leaders in healthcare are so entrenched in the status quo and don't really believe in the possibility of radical change. Like how many people believe that it's possible for us to ever get to a single payer health system where we don't have these disparities among all these different programs. How many people even believe it's possible for us to have a public option?
True. And I guess we may now have that debate more fully. We'll see. We have what appears to be a very bold new administration in Washington doing
I know, it's
things
exciting,
that are
isn't it?
surprising people. So
Yep, it is
guessing
exciting.
that maybe there'll be a chance to have that debate, that fight, that democratic process to win things that have a lot of currency in these times.
I feel hopeful. I feel, with the change in administration, I do feel hopeful. And I feel that with all the things that have happened to us over the past year, both the pandemic and all of the protests around social justice and the criminal justice system, I do feel that we have a moment of opportunity. Frequently in this country, significant change comes during times of crisis.
Yes.
And I do think that, we have been through a crisis and we may have opportunity for some significant change as a result of that. And so I am hopeful, and I am going to be pushing every day for that change. And part of pushing is really highlighting the impact of these inequities that we have in communities like ours. And then talking about the solutions.
The infrastructure investments may get to that as well. Some are saying now we realize things that we maybe knew but weren't clear about, like the digital divide, that now we're realizing in the modern world of technological power that this is now a utility, and that building out broadband and equipping people with tools to use it will educate children, will educate adults, will have a range of possibilities, and that it's like electrification or the highway system were back under FDR. So very interesting way to think about foundational changes that really need to be made. I know we had a question in here because, as you say, single payer, at least complete payers, that would be
universal coverage would be nice.
Yeah, could cover, here's a question, can cover California, reach everyone in the community? Are there policy changes needed to get all onto some kind of health insurance to assist in payment of better health care? So kind of to the point you're making, I don't know if you have more comments.
Well, I guess one interesting thing about the Affordable Care Act is that Covered California was actually a pretty small part of it. Covered California is important, but it covers a very small percentage of our patients and of people who live in our community. The vast majority of people in our community are covered by Medicaid, not by Covered California. Covered California provides individual coverage for people who have incomes that are higher than the Medicaid population.
The near poor.
Yes, and for people who don't have employer coverage. And the idea of Covered California is to make that individual coverage affordable and to subsidize it and standardize it. So it's an important part of the insurance market, but it's a pretty small part of the market. The big bang for us is in changing Medicaid. And, I tell people that I'm a proponent of Medicare for all because that would raise the floor, for my community. Most providers see Medicare as an inadequate program that pays low rates. Most hospitals are really passionately against Medicare for all because they see that lowering the bar for their payments. Now imagine how much lower Medicaid is than Medicare. So for my community, it would be a
For
step
you, it'd
up.
be a big raise.
Yes,
You'd
but
be in much better
for
shape.
most providers, they see it as a step down.
Sure.
Yeah. So I really feel that we need to have that conversation. And I appreciate what the insurance exchanges have done, but it's a very small percentage of our community.
Very. I hadn't thought about it that way, but I'm intrigued to hear you argue for universal one-payer, long-standing debate in this country, and can we make that big a change, and how do
Well,
we
as I get
these?
older, I tell people as I get older, I get more liberal. And I don't think we're going to solve the affordability problem or the problem of healthcare costs in this country until we have a more consolidated payment system. The way that they control costs in every other country is through a budget, by saying, this is how much money we're going to spend on healthcare. We don't do that in this country. And we've been unable to solve the cost problem. And in our country, the cost problem is a price problem.
Well, then managed care and value-based reimbursement are probably at least favorable on your list as well. Or not?
I would not, value-based, yes. I have to say managed care, I think, is not the solution either. I spent a lot of my career working in a managed care environment.
Right.
And I think that managing care is important. But if you don't have adequate resources, it's still going to be a problem. And if you have fragmentation in the market, it's still going to be a problem, of not being able to move the market and change what's going on in the market. And that's why over time I've really come to believe more in, moving toward Medicare for all and having consolidation on the payment side, but still having a private delivery system.
Yeah, and you need competition in there somewhere for sure. And well, there's you have very stirring views and and inspiring. No, you do. So do we have some other questions from the field? I'm seeing some adoring comments, some admiration, some appreciation, which
I appreciate that very much.
Are there other questions? If not, I'm going to ask Dr. Batchlor if she has some last remarks she'd like to make, but I want to be sure everyone's had a chance. This, I think, has been a very thoughtful discussion, some excellent questions coming forward, and so we appreciate that people are fully engaged. It would be hard to resist that, I think, with this presentation. Nonetheless, people are stepping up, so that's great.
Well, I think in summary, I would say that I think that COVID has given us an unusual opportunity to see the inequities in our health system up close. And I hope that I have made the case that, we really have a separate and unequal system of funding healthcare in our country. And that is one of the fundamental drivers of the inequities that we're seeing, is the underinvestment in underserved communities. And I hope that we are motivated to change that now that we can see that we're all connected and, we're all in this together. And if our essential workers in our underserved communities are infected, then, we can't isolate that in one community, and the impact of that is going to go throughout our whole community. So let's get on the ball and start making these improvements.
Well, I imagine you can all see then why, for me personally, Dr. Elaine Batchlor is quite a hero and quite an inspiring thought leader and change agent. And we all want to step up, not just with respect, but to step forward and take action from this, because she's making this investment of her time, but she's calling us out. Because this is the time where there is an opportunity for change. Things are more flexible. So I think if you wanted to pay her for this presentation, which we're not, we would we would take action and we would be inspired to move and join the forces for redesign to really create solutions to end these frightening, deep inequities and these structural dilemmas. Now that we see them so clearly, we have a moment. So I'm going to deeply thank you, Elaine, for who you are and what you have brought us here.
Well, thank you
very
very much for giving me an opportunity to talk about issues that I cared very passionately about. So I appreciate that. And I appreciate the audience that participated and asked such thoughtful questions and that clearly cares about the same issues. So thank you all.
And we have a website for mlkch.org where you can learn more about this great hospital, which can always use more support, whether it's time or other resources. And of course, we have our own website. So we celebrate this opportunity to think together. It's quite a TGIF to lift and inspire and drive us forward. So thank you so much. And thank you all for attending. We so appreciate it.
Yep. Have a good weekend.
You too. Thank you very much.